Hello everyone, my name is Kamya. I'm a student nurse from Western Sydney University. So in today's video, I'm going to consider one of the most serious heart diseases, that is heart failure. As we all know, heart failure is a major public health challenge. And according to National Heart Foundation of Australia, 480,000 people in Australia are recorded with heart failure. And it is estimated that prevalence of heart failure is around 1.5 to 2%. So in this presentation, my main focus will be on clinical manifestations of heart failure and pathogenesis causing these clinical manifestations. To discuss these, I'll be basing my presentation on this case study of Mrs. Brown, who's diagnosed with acute exacerbation of chronic heart failure. Before moving to the clinical manifestations, let me tell you what heart failure is. Heart failure is a condition in which heart is unable to maintain adequate cardiac output to meet the tissue demands of the metabolizing organs of the body. So chronic heart failure can normally arise from structural and functional impairment of the heart. Let's discuss Mrs. Brown's clinical manifestations. Firstly, we are going to investigate about the auscultation of lungs. A patient with heart failure normally has decreased stroke volume, which will therefore reduce the cardiac output. The body thus tries to maintain cardiac output back to normal using several compensatory mechanisms. The primary compensatory mechanisms are neuroendocrine endocrine responses, including activation of sympathetic nervous system and renin-angiotensin-aldosterone system. These are activated to counter the impaired function and maintain the cardiac output. A reduction in cardiac output leads to reduced renal perfusion, which stimulates release of renin in the kidneys. Renin then acts on the angiotensin and in the liver to make angiotensin 1. This promptly converted to angiotensin 2 on the surface of pulmonary and renal endothelium, which directly increases vasoconstriction and promotes the release of aldosterone from adrenal cortex. Aldosterone stimulates sodium and water reabsorption in renal tubules, promoting water retention. Thus, activation of the RAS leads to increased circulating blood volume, which will increase the preload with the aim to cause a stretch in the myocardium and increase the stroke volume to improve cardiac output, which is known as Frank-Starling mechanism. But as preload continues to increase, it causes a stretching of the myocardium, which ultimately results in dysfunction of the ventricles tissues and reduced contractility. Eventually, this curve of Frank-Starling becomes flat and even downwards as the heart muscle decompensate and compensatory mechanism is exhausted. When the left ventricle fails to contract properly, the heart pressure increases and vascular volume redistribute into the lungs, which will result in rise in pulmonary capillary hydrostatic pressure. Backfilling of excess fluids into the lungs, when the hydrostatic pressure exceeds on oncotic pressure, fluid moves out into the interstitial spaces, and the lymphatic system are unable to remove the flow of fluid out of the capillaries. And this results in acute pulmonary edema. And on examination, inspiratory crackles over the lung bases are revealed, which we can see in the case of Mrs. Brown. So the next clinical manifestation which I'm going to talk about are dyspnea, increased respiratory rate, and reduced oxygen saturation. So dyspnea is one of the main symptoms of chronic heart failure. It is defined as the abnormal sensation of uncomfortable breathing. Let's look at the pathophysiological mechanisms. So due to the ineffective forward flow from the left ventricle, there is backfill of pressure in the lungs, which ultimately leads to rise in pulmonary venous pressure and extravasation of fluid into interstitial space and lung alveoli. A swollen alveolar capillary membrane reduces gas exchange. So chemoreceptors in the carotid bodies and medulla will supply information regarding alteration in the blood gas levels, and this will stimulate vasomotor regulator in the medulla. From medulla, nerve impulses are sent to the pons, and which regulates respiratory rate. This sends signal to our lungs to breathe faster and deeper, resulting in dyspnea and increased respiratory rate. The additional fluid in the alveolar spaces slows diffusion of oxygen and carbon dioxide. It results in insufficiency of total quantity of oxygen within blood perfusing a tissue and leads to hypoxia, which means low saturation of oxygen. low oxygen saturation in the body. Now let's look at the other signs and symptoms experienced by Mrs. Brown, which are tachycardia, atrial fibrillation, and increased blood pressure. In an order to maintain the cardiac output, in the face of decreased myocardial contractile function, the baroreceptor reflex supports blood pressure changes and heart rate changes. So baroreceptors situated in the walls of the aortic arc and carotid arteries are stimulated by the amount of stretch in the blood vessel due to reduced blood pressure. This triggers vasomotor center to activate sympathetic nervous system and result in release of catecholamines, norepinephrine and epinephrine, which enhances the heart rate, contractility, and afterload via peripheral vasoconstriction, thus increasing the blood pressure and the heart rate. The renin-angiotensin-aldosterone system also plays an important role in blood pressure by moderating vascular tone and influencing the sodium and water retention by the kidneys to increase blood volume. Atrial fibrillation is the fastest rate triggered by irregular electrical impulses in the upper chamber of the heart. In chronic heart failure, the activation of RAS and neurohumoral hormonal responses triggers inadequate physiological changes, which include raised filling pressures and afterload. These changes in raised left atrial stretch and fibrosis, leading to the progress of conduction abnormalities and resulting in atrial fibrillation. So, my presentation was based on the clinical manifestations identified, and it is evident that Mrs. Brown's condition of chronic heart failure is exacerbating. So, possible objective for treatment includes control of arrhythmias, myocardial preservation, preservation of renal function, reduction in congestion, and blood pressure control. So learning these clinical manifestations and pathogenesis assist us nurses in understanding patient's condition better. Thank you.